So good morning and thank you all for coming. My name is Christopher Greb. I'm the operations manager for McClungy Ambulance Corps. My own disclosure is I'm not Dr. Bruce Feldman. I thank you all for coming today. Today marks an important part on our journey for bringing mobile integrated healthcare to the Lehigh Valley. About 2 years ago, Dr. Feldman ran into Orlando in an elevator somewhere around here. Orlando was previously the MI alert coordinator for the network and said, you know, we had a lot of success with using paramedics in the MI alert program. What if they could do something for heart failure? Fast forward 2 years, and here we are today. For some reason, Orlando gave me a call and asked if I would help with this. I'm still not sure why he picked me, but he did. So I'm happy to be a part of this. When he came to me, I remembered that in EMS leadership across the state and country, a lot of talk about community paramedicine, what we call it, or mobile integrated healthcare, two terms used interchangeably. And nobody here knew how to do it. Where do you start? Like when you want to work with a local health network of 17, 20,000 people, who do you talk to first? And what I found out is the answer is everybody. So over 2 years, I kind of feel bad that I don't remember everybody that we've met in hundreds of meetings, and hundreds of people that we've touched, and hundreds of people that have supported us. So I thank you all for coming. I really do appreciate the opportunity to share this information with you and introduce Dr. Bruce Feldman to talk about what we learned.
Thank you, Chris. And I want to echo just a theme here that this project could not have occurred without lots of support from lots of different people. And that's actually what makes this thing so exciting. Everyone who's heard about this concept and this project has raised their eyebrows with excitement and allowed and played their own role to make this work and overcome the obstacles that inevitably occur when you create a new process of care involving multiple systems in a community of healthcare. But before I talk about in detail the actual feasibility trial, which we were going to go over in detail, I want to make sure that everyone understands the background of how we got to this concept. So it's very important to first start out with, I'm a cardiologist. I take care of patients with heart disease and heart failure every day. And one of the observations that I've made personally is the frequency with which people return to the hospital after discharge. And they return soon. To exemplify the significance of this event, this is data on a slide here for you, demonstrating the rehospitalization rates among 40,000 patients across our country, all of whom are over the age of 65, documented in the Get With the Guidelines Heart Failure Registry. And the important point to appreciate is that in years, 2, 3, 4, and 5 years of time, almost everybody is readmitted with this disease. It is a serious disease that progresses and eventually leads to death. But one of the important observations in this graph that I want to bring your attention to is that the readmissions begin very early. So around a half a year, there's almost a 60% readmission rate. And in 1 month or so, there's close to a 20 to 25% readmission rate. 1 in 4, 1 in 5 people are readmitted. Now, from a patient's point of view, when you discharge a patient and say there's a 1 in 4 chance you're going to be right back here in 30 days, that's very disheartening. And one of the challenges is, you know, is this real? Is this a reproducible phenomenon? Is this just data? So CMS tackled this problem, and back in 2011, 2014, through that time window, they documented national readmission rates to be around 22%, consistent with this registry of data. We looked at our own readmission rate in our own hospital system at Cedar Crest. From 2012 to 2015, 25% readmission rate among 1,700 patients. Serious problem. And more recently, 2016, it remained the same. In fact, I don't have the most recent data on the slide, but it is still the same. It's in the range of 24% readmission rates. If we ask the question, when in this 30-day window do these readmissions occur? Most of them occur very quickly within the first week or two. And if we ask the question, why? Why are these readmissions happening? What's interesting, and this is not from our own program, this is Dr. Krumholz's data from Yale. He did a national analysis of why people are readmitted, in part due to the heart failure syndrome, but even after they're discharged with lung disease or lung infections or GI problems. And an interesting pattern was documented. And roughly 2/3 of these readmissions have nothing to do with the primary admission. In the heart failure group, approximately 1/3 of the patients are readmitted with their heart failure syndrome being exacerbated, either because maybe we didn't do a good job, or maybe the disease is just so aggressive that we can't control its progress. But if we focus on the 2/3 of the patients that were readmitted and ask why were they readmitted, what happened? And you can imagine there are many factors that go into this problem. Patients don't take their medications. They may not go to the drugstore to buy them. They may not be able to afford them. Or they may actually get the medicines, but they don't take them. They're not compliant with dietary restrictions. If they have a problem at home, they may or may not seek care. They may not call their doctor to ask for advice. They may ask for advice and get poor advice from a family member. And frequently, when they do ask for advice, the common response from a medical provider when they call an office, for example, go to the emergency room. The office cannot accommodate patients on short notice. The office staff cannot ask a nurse to go to the home on short notice. That resource does not exist anywhere in the country. Sure, we can have nurses go electively, but the idea on short notice of a nurse, visiting nurse, going to a home is not currently an effective, real process. All these variables are at play that contribute to these readmissions. There are other subtle ones. Patients are very frightened at home, and they don't understand what's wrong. And that often leaves them on their own, just to go back to the emergency room. You can define all of these variables, but it's very difficult to measure them. But we know, and clinicians and nurses know, these are real factors that govern what happens to patients' care. And when patients do get readmitted, there is a financial penalty. I don't know what the current penalties are for our own program. I've been inquiring, trying to get that data. It's not easy to capture. But this was an analysis from the Kaiser Group. They did this analysis in 2015, a national assessment, and they said that 80% of hospitals that had readmissions within 30 days were penalized in some way financially. And a lot of these hospitals were teaching hospitals, and the penalties were in big bucks. And so it really has an impact financially on the system of care financially, and it motivates us in part, not just for good patient care, but also for financial reasons, to say we need to grapple with this problem, and we need to rethink how we manage patients within that 30-day window post-discharge. There have been many, many different strategies tried, attempted in clinical research, prospective randomized trials to reduce readmissions. The Agency for Healthcare Research and Quality, they did a retrospective review of all the published trials, of which there were 47 randomized trials in 2013. And they were looking for what is the process that minimizes readmissions. And they identified, of these trials, only one showed some benefit in preventing 30-day readmissions. And what were the attributes of that randomized trial? It was a high-intensity home visit program. High-intensity home visit program. What exactly does that mean? It means that basically a care provider went to the home, spent time with the patient and or family, and in almost like an office visit encounter, but perhaps even more intense, because they can see the home environment where all of these issues are at play, social issues as well as medical issues that govern this process of readmissions. You know, there are many other things that have been tried. Let's take telemedicine, for example. You would think intuitively that if you had a sophisticated telemedicine program where you can monitor blood pressure, heart rate, oxygen saturations, body weight, with a device at home, information transmitted back to a central monitoring station with skilled nurse providers and or physicians, that would reduce readmissions. But there have been a number of randomized trials to test whether this works. 6 of them actually, all summarized here, involving more than 5,000 patients. It doesn't work. It does not reduce 30-day readmissions. Now, not to say that there's no benefit to this process, but if you use 30-day readmissions as an endpoint of the value of telemedicine, it doesn't prevent readmissions in the 30-day window. The other problem here is when a patient is expressing concern, either detected by telemedicine or they just call and ask for advice, as I mentioned earlier, the common response is go to an emergency room. And when they come to an emergency room, what does the emergency room team do? They readmit the patient. Nationally, this has been studied among close to 1 million ED visits in patients that were returning to the emergency room with heart failure symptomatology or a history of heart failure or recent hospitalization with heart failure. Almost all of them are readmitted because the ED physician doesn't know what to do with them. There's no specific treatment that they can say, do this and go home. Or you don't need to be admitted. There are medical legal issues that make them grapple with this as well. They don't have an option. And so, in our own program here at Cedar Crest, the number is about 90% of patients, maybe even higher, that are readmitted just by coming to the emergency room. Our program here recognized this problem and has created all kinds of strategies to reduce readmissions. We had a program with in-hospital nurse specialists to provide education. Sit with the patient, sit with the family, teach them about diet, teach them about the importance of the medications. We have a community care team that contacts the patient by phone. How are you? Did you get your medications? Do you have any issues? Can we provide services for you? We have telemedicine and special heart failure clinics and heart failure nurses. Obviously, our ED department is always there for patients, and our doctor's offices, when they can accommodate, is there for patients. And we have visiting nurses that provide home care. All these programs exist in our community. But the thing that struck me is that despite all these programs, our readmission rates remain the same. They didn't change. They remain the same. None of the programs that exist today were effective in really significantly reducing 30-day readmissions. And if I ask the question, do we have a high-intensity home visiting program within the first 30 days, the answer was no. And when you contemplate different strategies to reduce readmissions, not only must you consider the potential benefit of that strategy, but there's also a potential risk side to whatever you may choose, whatever that process is. This was a pretty frightening observation that was published by Dr. Yancey. He's kind of one of the national leaders in heart failure management from the American College of Cardiology. And basically, they observed readmission rates over time from 2008 to 2015, plotted in red. Here's when they initiated the hospital readmission reduction program, efforts around the country to reduce readmissions. And you can see that the readmission rates dropped from around 25% or so down to around 23%. Not much of a drop, but I mean a trend in the right direction. But the reason they published this data was the following. In blue was 30-day risk-adjusted mortality. When this program around the country was implemented, doctors and programs everywhere around the country trying to reduce readmissions, we started to see an increase in mortality. Pointing out the simple fact that any new process of care has to measure not only its benefit, but the risk side of that program. So, this is where I come in, and Orlando and Chris come in. And we got together, and we said, what can we do that's different and potentially helpful without causing harm? Now, I had the privilege of sitting on the truck of an EMS program, because I was involved with the MI Alert program, and I wanted to know what did EMS people do? You know? And what did I observe? I went with them and sat in the truck. I observed that they don't do anything unless there's an emergency. And when there's an emergency, they can get anywhere within 5 minutes really quick. But most of their day, they're not doing anything. They stand, they're really bright, they're very enthusiastic, they want to play a role in healthcare, but most of their time is spent idle. And I thought, wow, what a resource that we're not using properly. Could we consider paramedics to assist with this problem? So I did some searching, there's a lot of published literature out there about using paramedic practitioners to help in care outside the hospital setting, beyond emergencies. And that gave me some promise that maybe we could take advantage of a paramedical community healthcare program in our system if we could create that. But as you can imagine, there are huge obstacles to creating a new program. But we created this basic hypothesis. We said, compared to the standard care that we currently offer patients, house calls by a mobile integrated health paramedic program would reduce 30-day readmissions for heart failure patients and, importantly, improve patients' perception of care. And we had a secondary hypothesis that compared to standard care, house calls by mobile integrated health paramedics would reduce all-cause readmissions, not just heart failure readmissions, within 30 days. Now, to test that hypothesis, from a scientific point of view, you need a randomized trial, which is a pretty involved process. But we thought, before we get involved in creating a randomized trial, we need to determine, is the basic process feasible? And that's what led to this program. The house calls by mobile integrated health paramedics feasibility study. This was an IRB-approved program, grant-funded from the Full Trust Research and Development Fund. We began entry of patients in August 2017 and terminated the trial in May. And I'll share with you what we learned. First, we learned that you need a team of people, as was already emphasized. And we had a great research team, and Orlando and Chris were important parts of that team. We had support from our ED team. Volunteers who functioned as command physicians volunteered their time to be on call and available at a moment's notice to assist with any problem at home if a paramedic was at the home and had a concern and we needed to provide therapy at home, such as IV diuretics, for example. The EMS physician or the EMS provider cannot do that on their own. And believe it or not, a cardiologist can't give them the order to do that. By state law, it can only come from a command physician. So we had to have a third person involved in the loop. And creating that was the challenge. But we were very fortunate to have support from our ED team to make that happen. Most important, of course, is we had to have specially trained paramedics. The paramedics who were either volunteer or voted to be participants had to attend a special training program. They had a day of academic education, of lectures from experts, physicians, nurse practitioners. They had to have real-time mentoring at the bedside in the heart failure clinic with our nurse practitioners. We even had a mock drill in my home where I was the patient to work out all of the logistical issues to make sure that they were trained on how to manage heart failure patients and what their unique attributes were and how to recognize concerns. We had support for this program from multiple parties. Of course, the community EMS systems all were enthusiastic and contributed to their personnel. They provided us with paramedics. The Pennsylvania EMS Council supported the concept. Our Chief Transformation Officer, Dr. Debbie Salas-Lopez, was very supportive. We had support from our heart failure specialist, Dr. Hawa, who was valuable in providing education. And in the room, Alma is here, Denise here are from our heart failure program providing education for paramedics. We had support from Nori, from our research team, and of course from the grants team, without which we couldn't go anywhere. So there were lots of people involved. Here's what we accomplished. Number one, we created professional contract agreements between our hospital and 5 regional EMS organizations. It's a sentence, but there was a lot to that, as you can imagine. We identified 9 paramedics. They were selected. They completed city training, which is a requirement in order to participate in research, and they had heart failure training, as I mentioned. And we gave them a special title. After they completed their training, they were referred to as a mobile integrated health paramedic. And then, as I mentioned, we had ED physicians who volunteered their time to be on call. We were able to identify 20 patients who were willing to participate in this feasibility trial. Each of them had an important characteristic. They had stage C heart failure. Stage C means they were sick. They were not end stage, which we refer to as stage D. Stage D means despite medical therapy, despite surgical therapy, despite device therapy, they continue to have signs and symptoms of heart failure refractory to these types of treatments. These were patients who would respond to treatment, seemingly improve, were able to go home, and willing to participate. And all of the 20 patients had an initial encounter with a mobile integrated health paramedic 2 or 3 days post-discharge, and all but one had a second scheduled visit 15 days post-discharge. What about that one? He was homeless. Couldn't find him. But all the other participants had these scheduled visits during that window of time, 2 to 15 days, when most readmissions occur. 10 of the patients required an urgent, unscheduled visit. That was built into the protocol. At any time during the first 30 days, at the request of a medical provider, not the patient, but a medical provider, an urgent house call could be made within a couple of hours of concern. Not as an emergency, I got to be there in 5 minutes, but in a relatively short time. There were 10 patients who needed urgent house calls. One of those patients got IV diuretics, so that whole process worked. The link between the patient and command physician and the cardiologist all worked so that we could provide home IV diuretic therapy so the patient did not have to be transported to the emergency room. There were emergency room visits in 4 patients. Only 1 was admitted. The other 3 were discharged for outpatient follow-up by paramedics. There were 4 patients who had unplanned office visits as well. In summary, what we observed in this feasibility project among these 20 patients was the 30-day heart failure readmission rate was 5%. And the all-cause readmission rate was 15%. Those numbers are exciting, they're supportive, but keep in mind, this is just 20 patients and it's a feasibility trial. We obviously need a lot more volume of patients to really show that this is a valuable process, but it certainly supports the concept. Importantly, there were no adverse effects. There were no deaths. Patients received a request to fill out a little form so we could govern from their point of view their perception of this process. We also sent a survey to the medical providers who were participating to get their perception of the process. And there were no concerns expressed that were serious concerns. There were concerns from the medical providers. One of the important ones was, how do you document the encounter in EPIC? Where is the document? And of course, we had a process for doing that, but it wasn't an ideal process. We learned from every one of the encounters something a little bit. From every of the 20 patients, whenever there was a scheduled visit or an unscheduled urgent visit, there was a lesson to be learned. How can we do a little bit better the next time around? But the bottom line, after all the process was completed, we concluded that this process is feasible. It is definitely doable. And this is what's generated all the excitement, that despite all the obstacles we had, despite all of the potential problems that would stop this process, we were able to overcome them all with the help of everybody in this room. But most important, what we still need is a large randomized trial to show that this process really makes a difference. Now, our current next step is to extend the feasibility trial to an additional 20 patients who have stage D heart failure. They're much sicker. And we want to apply this concept to that 20 patient group to see how does it work in that subgroup. What are the issues? What are the concerns? Are there any potential adverse effects that can occur from ineffective communication, from errors in judgment, from poor documentation. We have IRB approval to do this. We have additional funding to do this, and it will occur. And we'll look forward to sharing that phase of this project. But most importantly, the real scientific evidence that shows that this is valuable, that has never been done anywhere in the country, by the way, is still required. And if that type of protocol, a randomized prospective trial in a large population of patients, shows that not only is it feasible, but that it really does reduce readmissions, cost of care, improves patients' perception without causing harm, this will become a national trend. So with that, I'm going to leave this over here to Orlando and just summarize the following for you very quickly, that we believe that a timely response to patient reports of any medical concern, whether it's new or worsening symptoms of heart failure or any other concern, will reduce ED evaluations and reduce readmissions, reduce cost of care, and improve the patient's perception of care. It is that timely response to patients' concerns that we need to implement, and we believe that paramedics have that ability to do that.
Okay, we'll save questions if you have to the end. We have a treat for you guys today. I'm really excited to bring one of our patients that was a participant of this process, along with one of our paramedics that was physically in the home working with this patient, to share their experience. Mind you, this patient, it came from him. He wanted to tell everybody how wonderful and helpful this process was. And so we were very lucky to have him here. Rick, Mr. Joliet, if you want to come up. So he will talk to you a little bit about what he experienced with this program and some of the lessons learned. And I won't spoil it too much, but Rick and Mr. Joliet, if you want to come up here. Okay.
Wow, look at all those people.
Good morning, everybody. My name is Rick Becker. I'm a flight paramedic with Lehigh Valley. I'm really happy to be here. The first thing I'd like to say is I wouldn't be here talking about this without the hard work of everybody. Dr. Feldman, Chris Orlando, and everybody that's been involved. And I think after you hear this short story, it's really going to solidify everything that Dr. Feldman said earlier. So I had the opportunity to do a 15-day follow-up visit for Victor. Is that okay?
Yeah.
All right. He's very entertaining, by the way. So I'm going to make this short because he's going to be the star of the day. So everything that Dr. Feldman said was absolutely correct. So I got to the house. Fortunately, he lived right here behind Cedar Crest. I came into the home, and I could very quickly identify what you talked about, Dr. Feldman, as far as the anxiety. Mr. Juliet's son, Michael, actually works in engineering and lives in the home with his dad. And you could see that anxiety. Something just wasn't right. I could tell by looking at him. He was tachypnic. He was pale. So I kind of figured something was wrong. They already had made some calls to try to get some help, and it seemed like I maybe got there at the right time. Fast forward, we just did, as Dr. Feldman said, just what we do as paramedics. So I assessed his blood pressure. I found him to be hypotense. I looked at his SpO2. That was decreased a little bit. He's a great historian, so he had this nice record of all his weights, and I could see his weight decreasing. And then just a quick little history of what's happened in the last 5 days. We found out that on Thursday, I was there Saturday, on Thursday he had a doctor's visit where they added an additional diuretic. So kind of one and one in my mind, like, yeah, maybe he's just a little bit over-diuresed here. So mind you, this is a Saturday. We're going to test this process now because I need expert medical consultation. Dr. Feldman was in San Francisco literally within 3 minutes of me activating that process. I had Dr. Feldman on the cell phone with me. We pretty quickly came to the conclusion, like, you know what, maybe that he is a little bit over-diuresed. Let's go ahead and just take one of those medications out. I asked if it would be okay if I came back the next day just to follow up, because that's just the type of person that I am. I want to make sure everything's okay. And we did that, and it fixed the problem. So I think it just really exemplifies everything that Dr. Feldman said. Personally, for me, I have a new friend with both Victor and the family, so I'll turn it over to Victor and let him tell you his part of the story.
Okay, I hope you can hear me. I'll try to be loud. You're looking at one lucky guy. I get emotional at times. I'm here, and I'm lucky to be alive. And I want to thank Dr. Feldman and Rick and everybody that's been involved in helping me. No, it's all right. I can stand. I get emotional.
I'll catch it.
Okay. Yeah, I'm the poster child for this program, I guess is what you would call it. But this is just one of many miracles in my life. So, anyway, but this is about this program and what does it mean to me. It's been a terrific help. As you can see on the one chart here, the doctors gave me a list of all the medications. And, you know, you got spirulactone and you name them. I couldn't even pronounce them. And what do you do with all of that? I had 13 different medications to take multiple times. And so I was overwhelmed. I didn't know how to do that. And I've since been talking to different people in hospice that say many of their patients have the same problem. They skip medications, they don't know what they've taken. It's a real problem. Well, I was lucky because Rick came up and he said, "We're going to give you my numbering program. You can remember numbers." I said, "Oh, hell yeah, I know that. I can do that. 1, 2, 3. So I don't know what the pills are necessarily, but I know that number 2, I take morning, noon, and evening. And number 3, I take morning and night. And I thought, well, I can do that. So Rick set up this chart, and it's just as slick as can be. You put all your medications on here and give them each a number and say how many times you take it. Now what's really nice about this is you can change it, you can update it. You can see I got number 4 crossed out, and besides the sorbite, I don't take any more. That's out, and here one that went from 10 milligrams to 5, and now back to 10. And but what's nice, if you look at the top up here, it just says morning, noon, evening, and bedtime. And I can look up there and say, well, let's see, number 2, I take morning, noon, and evening. Now, when I want to load my pill thing, I just have this here. I lay it down, and I have all the pills lined up by number. And I can do one quick check to be sure I got the right bottle and look at it, and then I just fill the pill thing. I can do like Monday, Tuesday, Thursday, Friday. I can skip over as many, however I want to do it. And it's very quick and it's accurate. So that has been just a tremendous help to me. And I don't know if any of you out here, all you doctors probably know all the names of this crap. You can follow through, but trust me, your patients can't. And particularly when they get to be my age. You know, I'm a little older than most of you. And I can tell you stories you wouldn't believe.
to see a bunch of my MIHP colleagues in the room here. This is just one of many experiences, so I'm sure you have some stories that you could tell where we've really made a difference, and I think this just exemplifies that. From a Lehigh Valley Health Network standpoint, I want to say I had the opportunity to see Dr. Nestor's state of the healthcare, state of our healthcare network, and it really made me think. So we talked about the triple aim, and certainly everything that we did in this program meets that triple aim. But he talked about the fourth, the quadruple aim, which is better colleague experience. And really, we can tie that together. Victor's son, Michael, is an employee of the health network and benefited from this. So I would say that we actually hit all four of those components with this. Thanks for listening to the report.
So this is Orlando Rivera, for those of you who don't, I'm sure you all know him. And he's going to talk a little bit about what we hope the future of our program will be.
Thank you, Chris. Thank you, Mr. Joliet. Very powerful story. He's one example of the benefits that this program has brought to our patients. So when Chris mentioned this in the beginning, so Dr. Feldman near the elevator, and he had this wild idea, hey, why can't we use paramedics to do this? I said, well, that's sort of happening elsewhere in the country, but he was quick to point out that although there's a lot of community paramedicine programs in the country, all of these are observational, and so they seem to work, but Dr. Feldman, being the scientist he is, he wants the first randomized controlled trial, and that truly is what we're after here. Groundbreaking, the first of its kind. We want to be the study that is cited by every other program in the country. So that's the goal. That was the first stage, was to prove that, hey, this is feasible. And why do we need to prove it's feasible here if it's being done all over the country? That did not make a lot of sense. Well, once you see one program, community paramedicine program, you've seen exactly one program. So depending on your population, you may have more mental health issues in that population, so those programs tend to focus on that, whereas in our region, we see a lot of cardiac issues. But it wasn't just that. It was the fact that we don't have unlimited resources at LVHN. We just don't. We have medevac. Our mission is critical care transports. We fly in the helicopters. We look cool, like Rick, with our little jumpsuits. Onesie, but we are a relatively small program with a very specific mission. So we don't have a million paramedics at our disposal. So part of this feasibility study focused on, okay, well, we do have many paramedics in the region, but they're not LVHN. So how do we get everybody and assemble a team that, although we're not within the same network, we work together like a well-oiled machine? Credit to Chris, he was able to go into all these squads and secure contracts. And if you know anything about LVHN and contracts, it's very easy. So it was, and everybody signed, and it went to legal, and before I got home, I got the email saying it's approved. But that was also part of feasibility. Can it be done? Can we engage EMS squads and do this? Well, the answer clearly was yes. So if you notice, we have a mat there with LVHN and his home squad on his feet and his shirt. We have LVHN medevac shirt and MIH. We have McConkey, we have Citronia, we have Northampton Regional, okay? So we have many squads that decided, you know what, let's join forces and work together. What that allowed us to do is expand our pool of providers to reach these patients. That's number one. Number two, what else did it do? Well, guess what? A lot of these squads now have a really good relationship with the LVHN because we're expanding their scope. Whereas before, they were just going to 911 calls. Now, we have specialized paramedics that do something that they didn't do before. And if you have a little bit of imagination, you can see how this could open the doors to other things that they can do or we can do together. So what are the next steps? So we just finished 20 patients. You saw the results today. We just secured funding for an additional 20 patients. The sickest of the sickest, stage D heart failure. Now, this is not going to be a walk in the park. So our existing paramedics, we're expanding the pool of those paramedics and we're retraining everybody to very narrow, specific heart failure assessments and treatments. We're refining our process to make sure that everything happens, learning the lessons from the 30 patients, that everything happens a little bit swifter. We found some hiccups along the way that we've been fixing, one of them being Epic. We use RedCap things, so she's the one that suggested that right there. So we created a RedCap. It's a research database, but we made it into an operational patient documentation platform. And if you see our RedCap project, you run out of the room because it's extensive. We kept adding things that we felt needed. And then we had to put a process together to put all that information and upload it right into Epic to where nobody can find an immediate hack. but it's in there. It's in there. If you have a day to search for it.
It's true.
So we are going to address that. So next steps, looking into the future, as we became known in the network, patients were promoting this. They would go to their doctor's office and talking about this. Other departments got wind of this, so we started getting emails. Hey, can you do this for our patients? We have pediatric oncology. What can you do for us? We have telemedicine. What can you do for us? So the interest started growing. So we started thinking, okay, well, if this is beneficial for heart failure, surely it may be beneficial to many other conditions. We can interact with other departments, and we have a whole lecture I'm not going to bore you about, but we have this flow chart that shows remote patient monitoring, home visiting nurses, even some of OASIS components, and how this community paramedicine program could supplement and enhance what they do. They call us the SWAT team of home visiting. Okay? You call us at 3 in the morning, we can dispatch our paramedics. Try and do that with anybody in the other service, right? So the last thing on the next step is we just secured funding, and credit to Laura, she's been instrumental in helping us secure lots of money. Like, we have this problem that people get throwing money at us. So thank you. So I think it's because our program is cool, but I'm biased. So we've just secured funding to educate all of our paramedics in the region. So you see that paramedics here, we don't just go to a squad and say, hey, Matt, who's working today? Can you send them over? We need a home visit. No. We have to pick the right paramedic that wants to do this, that maybe it's over the adrenaline aspect of this, because we're not running in the house, breaking the door to do a quick home visit and leave, right? But then we have to train them. Specifically, what do we teach? Population health, all those principles, right? Heart failure assessment, they spend time with Alma in the heart failure clinic to look at very specific heart failure assessments that go beyond what we see in EMS, which is by the time somebody's drowning in their own fluids, that's when we're there because they call 911. So we can recognize early on when somebody's getting in trouble. So we secure funding so that we can start the education process for all paramedics in the region. I'm happy to report that we got the Anderson grant, and we'll be able to very soon offer this education to paramedics. And why is that? Because we envision a future where this will be a standalone program, and we will be partnering with EMS squads all over the region and creating an army of partners that will then be able to manage a lot of our patients at a low cost, at very little risk for everybody. And, let's say the program doesn't work, but we don't have to fire or resize, 20,000 paramedics or whatever the number may be. So it's scalable. We believe in the project. We believe that the value is there. And if you have any questions, or if you're here and you haven't been part of this and have the desire to talk to Chris and I and how this could help your department, we'll be happy to sit down and talk to you and go over this. So that's all I have right now. So
this would, thank you all again for coming. This would open up for question and answer. We have 5 minutes officially, but we were smart and booked the room for an extra hour. So feel free to hang out and enjoy some of the refreshments in the back there. We'll take any broad questions, and anyone wants to meet up with us afterwards, feel free. Any questions?
So if there's no questions, I have a question. We have a guest today, Dr. Kors. Now, his program started a paramedic system to reduce readmissions, and it fizzled out, I think was the quote from one of the physicians in their program. It fizzled out. And maybe you can share with us your perception of why it fizzled out and what can we do to prevent this from fizzling out?
Yeah.
Bill Forrest, I'm the Chief Medical Officer at Lehigh Valley Hospital, Pocono. So we formed a community care network about 4 or 5 years ago. There were 2 arms to it. One is we had a program where we actually educated students at East Stroudsburg University, which is right next door to us, in their pre-medical or PA or science programs, and also Wilkes College of Pharmacy. That was one group. Then we worked with some of our paramedic squads to, for all the reasons and things that you mentioned today, to have a program like that in place. So we found actually for the short period of time that we kind of had the whole thing up and running, we had chosen COPD. There was very significant decrease in the readmission rates for our population. We had a system worked out with our emergency room where somebody on that list, we did it by LACE scores. I don't remember what LACE stands for, but something that they use to risk stratify patients. So instead of the patient getting admitted by one of Dr. Burmeister's colleagues, they would actually call care coordination and we would link them up with either the student or the paramedic. So unfortunately, because of funding, timing, resource, a merger, integration, all this other stuff that went on, the program fell by the wayside. The good news is I finally have convinced my CFO of the merits of doing it, because if you look at our readmission penalty, it's actually much cheaper from a financial point of view to do that than pay that. So we're looking forward to reinvigorating our program and getting it going again, and we'll be more than glad to take any of your grant money that you want to send us.
Sorry, we got it over. And actually, we'd like to say that we took some of the lessons learned from their program. One of their paramedics that was working for Suburban, actually, we just recently hired him to help with this program now. He's certified, the same certification organization that certifies the flight medics, certifies community paramedics. So he has a lot of ingrained knowledge in the program, so we're kind of going to keep building that down here. And we'd love to work together and see the entire LVH family
And
grow out.
Chris and I have been working on business plans, and we have a vision for the future that goes beyond this feasibility study. Is a great start, but we do see the value in this, with this business plan and a lot of lobbying from many of the people in this room. We're trying to stand this up. If we hope to do a randomized controlled trial with 200 patients in each arm, which is what Paul the brain over there tells us, we need to show significance. We're gonna need to build something and then run this feasibility trial on the back of that. So we're very aware of that, and Chris and I are working very hard behind the scenes trying to make that happen.
And there are ongoing obstacles to improve the efficiency of the whole program and its value. So for example, I mentioned the story of how by state law, paramedics can only take an order from a command position, which typically is an ED position. Do we really need a third party in the decision making when there's a paramedic in a home, since there's a concern, a heart failure specialist, a lung specialist, or whoever, to give this treatment? Instead of sending the patient to the emergency room, offer the treatment at home. Do we really need a command position to make that happen? And that step is an important one, and that's going to require a revision of state law from the EMS Council to make that work. And do the participants have to become command positions and whatever that's involved? That's one of the important obstacles. Do you have any comments for us?
It's something I'll research the easiest way, but ultimately I think they would have to become command physicians.
Yeah, based on the current state law.
Correct.
Right. So, and every state has different rules and regulations of how paramedics work and who they take orders from. But this, this has become an obstacle that has to be managed in the long run. It's not an obstacle to success, but it's one of the variables that we identify as the source of problems. The second major one, which has been commented on a couple of times, is how do we document the data in a meaningful way? So right now, the information is put in for those Epic users out there, the media tab, which is this kind of tab where everything goes that you don't know where to put it. There's all kinds of stuff in there, but it doesn't go under an encounter tab. But it is a patient encounter. It's not a hospital-based encounter. It's not an office-based encounter, but it is a serious encounter. And we're hoping to get the ethics system, the team, to put it in the encounter tab. But as you might imagine, if you work with the ethics team, to get that little step done is another serious obstacle.
So we've taken our 1 hour allotted. We appreciate you all coming, and we're going to be here hanging out for a little bit until they kick us out. Again, help yourself, and thank you again very much for coming.